Bismillah ar-Rahman ar-Rahim. Our lecture today is about intestinal obstruction. Our learning objective is to define the intestinal obstruction, to know what are the types and classifications, clinical features, diagnosis and its treatment, and to study a specific type of intestinal obstruction of surgical interest and their management. Definition of intestinal obstruction is mechanical or functional obstruction of the intestine which prevent the normal movement of the product of digestion through it. It usually presents with four cardinal features or signs of the disease. This include abdominal pain, vomiting, bloating, and failure of passage of gas or feces. Intestinal obstruction can be divided into a mechanical intestinal obstruction, which is called also dynamic intestinal obstruction, when there is physical obstruction of the bowel lumen, which is associated usually with increased peristalsis in an attempt to overcome the blockage. And the second one is the paralytic ileus or adynamic intestinal obstruction, when there is failure of passage of enteric content through the bowel wall and colon, usually the small bowel or the colon, that are not mechanically obstructed. And the main cause of that is that there is loss of peristalsis with subsequent dilatation of the bowel in the absence of an real obstructing lesion. We will talk about mechanical obstruction. Mechanical obstruction can be classified according to the followings, according to the speed of onset into acute, chronic, and acute on chronic, according to the site as a high or low obstruction, and according to the nature of disease, whether it is simple or strangulating, and according to the etiological factor of the disease. About the speed of the onset, it will determine whether the obstruction is acute, chronic, or acute on-chronic. In cases of acute obstruction, the onset is usually rapid and the symptoms are severe, while in chronic obstruction, the symptoms are insidious and slowly progressive. For example, in most cases of carcinoma of the large bowel, the progression is very slowly and insidious. Chronic obstruction might develop acute or symptoms as obstruction it suddenly becomes complete. For example, when a narrowed lumen becomes totally occluded by an specific bowel content, and then there will be change of obstruction from chronic into an acute on chronic obstruction. According to the site of obstruction might be classified into two types: the high type, where there is a small bowel obstruction, or the low type, where there is large bowel obstruction. According to the nature of disease, the obstruction can be divided into a simple or strangulated. Simple obstruction occurs when the bowel is occluded without a damage to the blood supply of that segment, while strangulated obstruction is when the blood supply to the involved segment of intestine is cut off. For example, in strangulated hernias, volvulus intussusception, or when the loop of intestine is occluded by a band or by adhesion and there is loss of blood supply. The ischemia, if it is left untreated, the ischemia will result in gangrene and perforation. It might follow and the patient will die from toxemia and septicemia. According to the etiological factor, when we consider any luminal or a tube, luminal structure or a tube, anywhere in the body, the causes of obstruction of such luminal structure is either within the lumen or in the wall or out from outside the wall. So it can be classified into three, according to the etiology, into three types. The causes in the lumen is by fecal impaction or presence of gallstones, as in gallstone ileus or a food bolus, or parasites, as in cases of Ascaris worm in the small bowel, or in cases of intussusception, where the intussusceptum will pass inside the lumen, causing an obstruction. In the wall, congenital atresia, inflammatory bowel disease like in Crohn's disease, which is a transmural disease causing obstruction, or a tumor of the bowel, whatever it is, small or large bowel, or diverticulitis of the colon, which is one of when the diverticulate gets inflamed and thickened and edema and will obstruct the lumen of the colon. Or outside the wall, we have to look for adhesions and bands, and this is the most common cause of intestinal obstruction in the surgical ward, or strangulated hernia as an external hernia, which is the most common, and internal hernia, which is less common. It is regarded as second most common cause of intestinal obstruction, and the third cause of intestinal obstruction is due to volvulus of the colon. It can also be useful to think about the obstruction as the most common cause in certain age group. And this can be divided into neonatal causes or neonatal obstruction. And the neonatal obstruction usually occurs due to congenital atresia or stenosis, as in duodenal atresia, imperforated anus, volvulus neonatorum, Hirschsprung disease, and meconium And during infancy, the interception, Hirschsprung disease, and strangulated hernia and obstructed this obstruction due to mucus diverticulum are the most common causes. In young adult and middle age, strangulated hernia adhesions and Crohn's disease are the most common causes, while in elderly, the strangulated hernia, carcinoma of the colon, and colonic diverticulia and impacted fecal material, it can be the causes in such age group. Strangulated hernia is an important cause of intestinal obstruction from infancy to old age. So we have to consider strangulated hernia in all age group, regardless of the age. The hernial orifices, it must be examined, and especially in cases of fatty people and fatty females, and looking for the femoral triangle, because usually the femoral hernias are small, and might be missed in cases of intestinal obstruction, the obstructed or strangulated femoral hernia, especially in fatty females. Pathologically, when the bowel gets obstructed by a simple occlusion, the bowel distal to the obstruction rapidly empty and become collapsed, while the bowel above the site of the obstruction become dilated, and partly it's filled with gas. Most of the gas is swallowed air, and partly with a fluid poured out by the intestinal wall together with gastric, biliary, pancreatic, and pancreatic secretion. So it is intestinal fluid, gastric, bile, and pancreatic fluid. To overcome this obstruction, there will be an increase in peristalsis, which result in intestinal colic, and the patient will develop colicky abdominal pain. As the bowel becomes distended, the blood supply to the intensely distended intestinal wall become impaired, and in extreme cases, there might be mucosal ulceration and even perforation. It will develop soon. Perforation may also occur from the pressure of a band or the edge of hernial neck on the bowel wall, producing local ischemic necrosis, and or from a pressure from within the lumen, as in cases of fecal mass, resulting in stercoral type of ulceration. In strangulated hernia, the integrity of the mucosal barrier is lost. As the ischemia, it will progress with time, so the bacteria and their toxin can no longer be contained in the lumen, and there will be transudation of microorganisms into the peritoneal cavity will rapidly take place and resulting in secondary peritonitis. If the obstruction is unrelieved, strangulation is followed by gangrene of the ischemic bowel and perforation. It will follow. The lethal cause of intestinal obstruction in strangulation is now due to different factors. The first factor is fluid and electrolyte imbalance and depletion, and the second one is protein loss within the gut. And the third one is due to toxemia, where there is migration of toxins and intestinal bacteria into the peritoneal cavity, which is either occurring through the intact ischemic bowel wall or through the perforation, and there will be absorption of these toxins and bacteria, resulting in septicemia, and the patient will die from that. Clinical features of intestinal obstruction. We have to consider 3 points when we are talking about the intestinal obstruction. The first one is to diagnose the intestinal obstruction. And the second one, by diagnosis, to see whether it is a simple or strangulating. Uh, regarding the diagnosis, we know that that diagnosis depends on the history and clinical examination, and by history we can the patient will present with colic abdominal pain, distension, absolute constipation, and vomiting. On examination, we have to look for the presence of a scar, especially in post-operative patients, if the patient have previous history of surgery, and we have to look for hernia, as we said that the hernia, obstructed external hernias, they are the second most common causes and should be considered in all age group. And the third point is whether the obstruction is simple or strangulated. The features suggesting strangulation are the following. Number one, there will be change of character of pain from colic to continuous, which means that the obstruction is complete. There will be some sort of tachycardia and pyrexia, and the bowel sounds become reduced or absent, and the patient will develop symptoms and signs of peritonism, where the abdomen becomes tender and rigid, and there will be like leukocytosis, which have been found on laboratory investigation on by using the complete blood picture or complete blood count, and there will be also raised C-reactive proteins. The pain is one of the symptoms, and usually it is colicky in nature. And in small bowel obstruction, it starts in the periumbilical area, while because the as we know that the small bowel is part of the midgut, while the distal colonic obstruction results in suprapubic pain, and it's also colicky. In postoperative obstruction, the colic may be discussed by the general discomfort of the operation and by opiates that has been usually given to the patient postoperatively to reduce the pain. So the pain, it might be vague and modulated by pain at the site of the surgery or by narcotic analgesia. This tension is a particularly marked symptom and sign in large bowel obstruction, and as the obstruction it gets higher, the obstruction, the distension, it will become less and less. Absolute constipation, or we call it obstipation, there will be failure of passage of feces and flatus. Although this is a usual feature of acute obstruction, partial or chronic obstruction may be accompanied by passage of a small amount of flatus. Absolute constipation is an early feature of large bowel obstruction, but late feature of small bowel obstruction, because as we know that if it is high, the distal part, distal to the obstruction, the patient might empty by peristalsis at first, and the patient will have a normal bowel motion or even flatus for one or twice before the obstruction it will become very evident. Vomiting is usually occur as an early sign in high obstruction, but it is not common, or it is sometimes it is absent in low or large bowel obstruction. In the later stages of intestinal obstruction, the vomiting may become feculent, but not fecal. As we know that when a patient develop intestinal obstruction, if it is distal at the ileal side or in the colon, with you might have vomiting of gastric content, which is colorless and acidic. We will vomit the golden yellow with a greeny hue bile vomitus, and then a green fluid, which is the jejunal fluid, and then the ileal fluid, which is feculent, where it is thick and golden in yellow in color, and it is of fetid odor. The importance of this feculent vomitus is very important, because it means that the patient loses all the gastric, all the duodenal, all the small bowel, including the jejunum and the content of the ileum, upper part of the ileum and part of the lower part of the ileum. So the patient will have severe electrolyte and acid base imbalance, and this is regarded as ominous as ominous sign in intestinal obstruction. True vomiting of feces can occur in cases of malignancy, especially carcinoma of the stomach, if it involves the colon and invade the colon. When there is necrosis of the tumor, In the center, you might have fistula between the stomach and the colon, resulting in gastrocolic fistula, resulting in vomiting of fecal material. On clinical examination, the patient is obviously dehydrated, especially if the vomiting is copious, and the patient will be in pain with colic abdominal pain and is rolling in bed. The pulse is elevated, but the temperature is usually normal. But if the temperature and pulse it rises both together, it means this it might suggest strangulation. The abdomen it becomes distended with visible peristalsis, but the visible peristalsis it can be a normally appearing and can be seen on inspection of the abdomen in thin people. On inspection, it is important to look carefully for two features: the presence of strangulated external hernia, which might require careful search in case of small strangulated femoral hernia in very obese and distended patient. And the second point, we have to look for the presence of an abdominal scar, intestinal obstruction in the presence of uh, the presence of the previous type of surgeries immediately suggests that the cause of the obstruction is band or adhesion. Palpation, the patient will have revealed general abdominal tenderness. A mask could be felt in cases of malignancies and carcinomas, and in interception where sausage-shaped mass it can be felt in the abdomen. The bowel sounds it might be accentuated, and later on it will become tingling and absent. Rectal examination should be done in all patients as we can palpate the prolapse, the apex of interception or fecal impaction or malignant mass in the rectum. Uh, Simple obstruction versus strangulated obstruction, uh, sometimes it will be very difficult to differentiate between the two. But the distinction is important because strangulated obstruction usually occur, and if it occurs, the mortality rate it might reach up to 15%. The features which suggest strangulation are toxic appearance of the patient with a rapid pulse and elevated in the body temperature, colicky abdominal pain, it will fade and becoming a continuous type of pain with peritonitis. Tenderness and abdominal rigidity are marked over the abdomen. The bowel sounds become reduced or absent, reflecting type of peritonitis and peritonism, and the white BC it becomes increased and mostly of the neutrophil, which is usually due to infected bowel. A special investigation might be done. Plain abdominal X-ray in erect and supine position are valuable in the diagnosis of intestinal obstruction. You might see multiple fluid levels in the central part of the abdomen, small bowel, because the bowel it is present in the central part of the abdomen. It is long tube, so there are multiple air fluid levels due to accumulation of fluid and the swallowed gas, and appearance of ladder pattern appearance of the dilated loop, and it is central in position. The X-ray, plain abdominal X-ray in supine position might show complete white lines that traverse the wall of the bowel with the width of from one bowel wall to the other. It is continuous, which is indicates the presence of vulvally conniventus or intestinal pleusia, as they call it. Sometimes you find a white line between the bowel walls, between the bowel loops, distended bowel loops. This indicates the presence of edema in the bowel and the presence of free fluid in the peritoneal cavity, and it might be an indication for surgical treatment because the bowel is distended, severely distended, and then edema, and there is a fluid in the peritoneal cavity. Large bowel obstruction usually lies peripherally and shows hostration of the tiny coli, and these hostrations they don't extend across the whole width of the bowel wall of the bowel lumen, and in a small percentage of cases, about 5%, the intestinal obstruction show no abnormality on a plain abdomen, and this is because the bowel is completely distended with the fluid in closed loop obstruction or without fluid levels produced by a coexisting gas. CT scan with oral water-soluble contrast, for example, gastrographin is particularly useful. It can localize the site of the obstruction. It can detect the obstructing lesion and colonic tumors and may diagnose an unusual hernias like obturator hernia, which are internal hernia, which is very difficult to be diagnosed by clinical examination. The water-soluble contrast study is an emergency contrast enema, which may be detect large bowel obstruction due to carcinoma or diverticular disease. Unlike the normal bowel barium enema, no pre-examination laxative is given because of the risk of exacerbating the obstruction and causing more serious complication, which is the perforation, if a closed loop obstruction is existed. The treatment, although the treatment of a specific cause of intestinal obstruction is considered under different headings, as we will see in the next lecture, the general principle can be applied in a chronic large bowel obstruction because of the slow progression or incomplete obstruction. The patient can be investigated at some leisure time. We have a time to do sigmoidoscopy and colonoscopy and barium enema, and it might be treated electively. But in cases of acute obstruction, which occurs of sudden onset, complete obstruction with the risk of strangulation, it is invariably an urgent problem requiring emergency surgical intervention. The operative preparation of acute obstruction includes nasogastric aspiration by nasogastric tube to lessen the risk of inhalation of gastric content during induction of anesthesia and decompressing the bowel. Intravenous type of fluids and the large amount of fluid, it's sequestrated within the gut lumen or into the peritoneal cavity, and also it is lost by vomiting, so a lot of fluids it should be given. The best type of solution which is given in case of intestinal obstruction is Hartmann solution, and sometimes if it is not available we use normal saline with potassium if the renal function is assessed and it will be it was normal. If the patient is shocked, a plasma expander might be given, and antibiotic should be given whenever strangulation is suspected and likely. The operative treatment, the affected bowel should be carefully inspected to determine its viability. And usually we check this viability at the site of the obstruction where a band or a margin of the hernial orifices have pressed against the bowel wall, or we check the whole segment in cases of closed loop obstruction, because in closed loop obstruction, the whole bowel, it might be affected and it will become ischemic. The non-viability is determined by signs, four signs. The first one is loss of peristalsis. The second is a normal shining appearance of the bowel. It is lost. The color becomes greenish or black, and there is loss of arterial pulsation of the blooding, supplying mesenteric. In cases of doubtful bowel, doubtful bowel, it might recover after relieving of the obstruction. Usually we relieve the obstruction. We put warm packs over the bowel for a few minutes, and the bowel color, it might change into a normal one, and the doubtful loop, it can be saved. If the extensive area of bowel are doubtful and viable, the doubtful about the viability, it may be worthwhile to replace the abdomen back into the peritoneal cavity and close the abdomen, and a second look operation should be done after 48 hours. The general principles is that when the small bowel intestinal obstruction can be in small bowel obstruction, the bowel, it can be resected and primarily anastomosed, and high safety and excellent result it can be achieved because of the good blood supply of the bowel. In cases of large bowel, it is treated by resection of the obstructed lesion. If it is on the right side of the colon, there will be a resection, a right hemicolectomy with the primary ileocolic anastomosis. If the obstruction is proximal to the splenic flexure. But if the obstruction is distal to the splenic flexure, then it should be managed by excision of the affected segment and exteriorizing the two ends as a temporary colostomy and a mucous fistula. If the distal end will not reach the surface, you might exteriorize the proximal segment as a colostomy, and you suture the distal segment and leave it in the pelvis as in cases of Hartmann procedure. This difference between the management of the small and large bowel obstruction, it reflects the presence of intra-abdominal bacterial flora and poor blood supply of the large bowel. Colonic primary anastomosis is very liable to leak in the presence of obstruction because of the ischemia. And when a primary colocolic anastomosis is performed, the proximal bowel is first lavaged via a catheter which is passed through the appendicular stump, flushing effluent along the colon and out via a large bowel tube in the proximal end of the colon. A defunctioning ileostomy might be performed at the same time to minimize the complication of anastomotic leak, which might occur due to following anastomosis in cases of obstruction. Conservative treatment it can be done as a first line in intestinal obstruction by giving the patient intravenous fluid and insert a nasogastric tube and do nasogastric aspiration. The indications of conservative treatment are only under the following conditions. Number one, distinction between the postoperative paralytic ileus or mechanical obstruction if it is uncertain. When a period of a careful observation is indicated, we have to take the time, especially in this type of obstruction. The second, when the obstruction is one of the repeated episodes where a massive intra-abdominal adhesions, patient have multiple operations, we think that there's massive intra-abdominal adhesions rendering surgery and adhesolysis become hazardous and the patient might develop fistulae. So a short period of conservative treatment should be indicated. But the conservative treatment should be abandoned if there is an increase in the distension, if there is aggravation of the pain, if the abdomen it becomes tender and rigid and raising pulse and increase in body temperature, which indicates that the bowel it gets strangulated, and this is an indication for abandoning the conservative treatment and to re-explore the abdomen. When chronic obstruction of the large bowel occurs, it is reasonable to attempt to remove the obstructing fecal material by enema and preparing the bowel and carry out a subsequent elective procedure.